into my talk about having primary care in psychiatry and maybe some of the smaller lifestyle measures that psychiatrists, mental health clinicians can address. And that's part of, I'm a public psychiatry fellow, so that's part of my training and education into looking into these health disparities and having more conferences and so forth like this. And the South of Market Mental Health Services actually also touches on integration and so forth, another CBHS clinic. So I did add a disclosure slide because I think industry is also a huge factor into all these access, healthcare disparities. It has another huge influence into why people make the choices that they do, their lifestyle choices. So I have no financial interests or any relationships to disclose. And some of the objectives that I hope to talk about, which have already been addressed by many of my colleagues on the panel, is areas where psychiatrists can incorporate primary care into our practice, recognizing some barriers to providing some of this basic primary care, and brainstorming solutions to increase collaboration as part of the. So starting with a slide, smoking is a main factor, and it doesn't just apply to people living with mental illness, but to everyone, including Olympic athletes. And tobacco use is the leading cause of preventable cause of death in the United States. But people who are living with mental illness are twice as likely to be smoking. And sometimes people may be thinking if they're smoking, they're at higher risk of smoking, they might not want to quit, but they do have very substantial quit rates as well, comparable to people, to just general people, because that's what we all are. And once again, just kind of highlighting how high the smoking status is amongst people with mental illness. It's almost, as I said, twice the number. So the numbers that are more statistically significant are the lifetime smokers. If you ever had a mental illness or any mental illness in the past month, 59% of are lifetime smokers compared to 39% without mental illness, or 55.3% if you ever had mental illness, compared to that number, 39%. So this was a population study in 2000, and there's more literature in the CDC and so forth also talking about smoking cessation and making it a larger public health issue for primary care, for psychiatry, behavioral health to be addressing. So one of the things that as a psychiatrist we should be doing, hopefully, or any type of clinician involved in caring for people with living with mental illness, is to always ask about the smoking history. And it seems so simple, but is often just not done. There are a number of things to be done in your 15, 30-minute check-in, and asking about smoking's history might just go to the wayside compared to cocaine, methamphetamine, all these other illnesses. But knowing that if there's one thing that you could be doing in an abstinence model, a harm reduction model is just addressing smoking cessation, it's always a key area to be discussing. So asking about it, advising for smoking cessation, bringing up some of these factors and how it can be factoring in on multiple things, not only their health, but also the economics. When you might not have the most money in your wallet, paying for cigarettes is something that people might relate to a little bit more if you're talking about how much it costs. And then knowing what resources that we have in San Francisco. As we mentioned, there's smoking cessation groups. Sometimes people don't feel comfortable or don't have the time to go to the smoking cessation groups. And across the nation, there's a bunch of telephone hotlines. So there's 1-800-NO-BUTS here, knowing when to refer for it. There's treatment that we can provide, and there's nicotine replacement therapy, Zyban, which is actually Wellbutrin, so you can be targeting both depression and also targeting smoking cessation, and Chantix as well. And then just knowing that smoking is something that is very difficult and has a lot of different factors in why people are smoking. There is a higher rate of people with mental illness smoking, and that's probably because it can decrease anxiety, it can decrease tension. There's a social aspect of smoking. If your peers are smoking, you may be smoking with them, addressing some of these environmental figures, and it can even have some biological factors, improving your attention, improving your concentration. So there's a lot of reasons why people may be smoking, and knowing and being aware of these issues so that when people decide, okay, maybe I will try smoking, that you can counsel them to be aware of some of these issues, of that they may have withdrawal, that it may be difficult, and one time if you stop, it doesn't mean that that's the end. So one other huge factor is that there's nicotine withdrawal, but there's also medication adjustments. A lot of the medications that we prescribe for people with mental illness is affected by smoking. So once you stop smoking, the rates of these medications might go up. And smoking in itself may also make these medications then less effective. So there's a huge push these days for hospitals to be smoke-free. And we send someone into the hospital, they get stable on a medication, and they come out, and if they resume smoking, that medication might not be as effective. So that kind of leads into the other thing, that you have all these medications that we prescribe, and a lot of them have side effects and drug interactions and so forth. And one of the main ones is metabolic syndrome. So this is a syndrome that is commonly caused by atypical antipsychotics. And we don't just use this for people with schizophrenia or bipolar disorder. It's commonly, as I was mentioning, the industry it's used so pervasively. So the idea of Seroquel, going to the dentist, being aware of that medication, people commonly prescribe it for anxiety, all of these off-label, but they have very serious side effects. Obesity, the waist circumference, this is a whole bunch of criteria of what it can cause. So it can cause abdominal obesity, elevated triglycerides, that's your fatty acids, elevated cholesterol, and decreasing the good cholesterol, which can help you in terms of prevention of heart disease and so forth.
Exhibit A right here, by the way, gained over 100 pounds on Zyprexa.
It is very disabling, and it also does not help with your mood, with your anxiety, with your self-esteem, and so it's a very difficult balance to be weighing for the risks of if someone is so paranoid that they can't get out, you want to prescribe a medication, but as someone who's prescribing this medication, to be aware that you also need to be monitoring for all these things of blood pressure, glucose, and so forth. So this is what we know it can cause. And this is the recommended guidelines by the APA, by the ADA, of getting a baseline weight, BMI, baseline waist circumference, blood pressure, blood glucose, and then routinely checking every 4 weeks, 8 weeks, 12 weeks, quarterly, and so forth, and more if there's abnormalities. And to also consider, as many people as have mentioned, if there is significant weight gain, significant elevated blood sugars and cholesterol, of considering switching to medications that are less likely to cause these symptoms. And so one of the things, as I was talking about, is that these lifestyle habits of weight and diet and exercise are very complex. We know that a healthy diet and regular exercise can improve your mood, can improve your energy level. We know that when you're not exercising and if you're eating more or eating less, that might also be a symptom of a mental illness. And as I was just mentioning, these medications also cause changes in your appetite and energy. So it's a very complicated issue of which is it, the chicken versus the egg. And so it's something that just needs to be addressed to try to tease out on a regular basis. But these are some of the barriers of trying to do this in a primary care psychiatric setting, in a psychiatric setting, is what are your resources of the setting? Is there equipment? Do you even have a blood pressure monitor? Very rarely will there be a phlebotomist or a accessible laboratory so that you can get your blood drawn. Is there an EMR, electronic medical record? Can you actually access these? If you do get the blood drawn, do you actually get the report? Can you share it with your colleagues in primary care? There's, as always mentioned, the time limitations. It's not something that's very simple to address these issues. And you're just kind of trying to decide which is the major issue, the main problem that's really upsetting the consumer who's coming in today, and making sure that though you still have to address what is going to be the thing that will ultimately shorten their lifespan. So kind of picking and choosing. And then there's just a general sense of discomfort, as Dr. Holt was saying, of, okay, we found out that the cholesterol is elevated for so what? I've changed the medication, lifestyle habits haven't changed that much. Do I want to start a medication that I don't really feel comfortable with, that I'm not as comfortable starting something for blood pressure, I'm not as comfortable starting something for cholesterol, and because these things have side effects as well. So potentially not wanting to ask because you might not necessarily want to know the answer. And as mentioned as well by many people, this difficulty communicating with multiple providers. With this metabolic syndrome, they may often be seeing primary care, they may be seeing people to manage their kidneys, to manage their heart, and that's all valuable information that would be helpful to know, but with time limitations, with a lack of technology to collaborate, it can be very difficult to get all the stuff done, and not to be redundant as well, to not be drawing the labs over and over again because you couldn't communicate. So that kind of goes into a little bit of don't ask, I don't want to know. There's a little bit too much information to be finding out. So some potential solutions would be just increased education on primary care interventions for psychiatrists. We do a lot of it goes both ways, increased behavioral health interventions for primary care, but feeling more comfortable for potentially starting a treatment for high cholesterol, statin, as well as smoking cessation. Improving communication and collaboration as the Affordable Care Act is all about, increasing collaboration, having maybe an access to a universal EMR. That might be the pipeline, but at least within different organizations and DPH, of getting them more integrated. So, and then as we've been talking a lot about this integrated behavioral health primary care programs. And so, as Dr. Holt was mentioning, there's the psychiatry consultant to primary care via telemedicine or directly in the clinic located. There's also primary care could potentially be a primary care consultant to psychiatry. And what we have at the South of Market Mental Health is just having co-located clinics. So you have access to someone, and people who are really having difficulty linking with primary care, psychiatry, if they're in the same clinic, there might be a better chance for someone to come in and feel less stigmatized and able to talk and to share labs and to collaborate and come up with something that both the consumer, psychiatrist, primary care all feel satisfied and will really be improving health. So some take-home points is that health maintenance just has far-reaching consequences, both on your lifespan, your mood, your energy, and smoking cessation, because I think that's kind of a key one that really is such a leading cause of mortality and morbidity. So it should be a discussion point for every clinician, psychiatrist, therapist, anyone. And education, just more education, more discussion, more conferences such as this can really open the dialogue on more preventive care and treatment options then. So, any questions?
Hi. I'm sorry to say, Dr. Miglani, because you represent the medical model very much so. Because to me, medical model says, something wrong with you, you need to be fixed, instead of really also looking at the environment and what's going on. I'm going back again to the holistic approach of any disabilities. And that sort of like, I understand what you're saying, prevention and, all that, and then, communication among primary carers and psychiatrists and all that, but it's really bigger than that. And the foundation of disability is really that in order to overcome that stigmatization is not to look at the person only, but really look at the environment. And I think it's really, really important that you take that into consideration.
I appreciate your comment. I agree to look at the person in the holistic model. The point of this discussion was actually to take more ownership on ourselves for how we're contributing to a lot of the illness based on the environment can cause it, but so can ourselves, so can the treatment. And that's just my take-home message of that we have to take some ownership as well, that these medications might not be as simple as treating the symptom and so forth. They have a lot of negative side effects as well.
And in terms of changing the system and making improvements, we want to try to make improvements where we can get the maximum bang for the buck. And if the physicians are willing to take responsibility for smoking cessation, that's half of the morbidity of people that are going through mental health. They're more likely to die from smoking-related problems than related to issues related to mental health or depression or otherwise. So it's not a small deal for physicians to be looking at smoking. On the other hand, the issues that you're also talking about are not a small deal too, and so we need to be looking at, okay, which of these can we do, what order should we do them, and then how do we get there to this kind of nirvana of a system that we all know that we really want. So again, I don't think it's an either or, but this is what I think the doctors in Dr. Meghali's clinic are taking responsibility for, and I actually commend you because it's a really big step. It's something that, it's not intuitive, but when you think through it, it's probably the most important thing for her in her clinic to do for her patients. So.
And I'll add just really quickly that from a client perspective, from a patient perspective, it can be overwhelming to be bombarded with a lot of things that I need to change. And I really liked what you said about approaching smoking cessation from an economic standpoint, from saying, let's talk about how this is affecting you financially, because that's a very oblique angle to approach it from. That's not something that I would find personally threatening or that I could perceive as being judgmental. That'd be like, wow, yeah, I actually do spend more than I can really afford on that. Maybe it would be a good idea to talk about that. So it's just a matter of being aware that someone who has experienced mental health conditions might feel cornered with some of that. And I think that's something that to be aware of and to work with. Because I think what you're doing is great. What you're talking about is great. It's just a matter of presenting it in a manner to a patient that we're willing to receive.
Yeah, I had one of my patients tell me that what really impacted her about smoking is that if she stopped smoking, she was worried she was going to gain weight. And being a man, it's like what? But this is where again, gender issues come in, right? Male psychiatrists, women psychiatrists. There's opportunity for me to learn. But I hope that you'll share these stories with your doctors because you'll be teaching them what you need and how to best speak with you about the next issue that comes on up. So,
okay, I'd like to turn to Pam Cohen. We're lucky to have an attorney on the panel, although the last speaker, certainly not least, it's very important for patients and others and providers just to know where the legal parameters are in terms of what are the rights and obligations of patient and doctor, not just with respect to privacy rights, but under the Americans with Disabilities Act, its predecessor, Section 504, and the state laws under UNRU or any other statute. Pam?
Thanks, Steve. I know we're already past 4 o'clock, so I'll be very, very brief. So connecting the legal rights to stigma, understanding and working to enforce your legal rights can promote your sense of autonomy, can help deal with some of these stigma issues. So we're not talking about something that's completely outside of this whole discussion of stigma. And Rob and I are working at Disability Rights California under a grant by the California Mental Health Services Administration, which is about stigma and discrimination reduction, mental health stigma and discrimination reduction. So it's really part of the same thing. Rob and I both have some fact sheets out in the front table on these issues, and there's one that's called Access to Healthcare that summarizes what's in my presentation here. So you can pick that up. Also, in case I forget to say, we also have evaluations that we have to use because under this grant. So we would very much appreciate it if you'd pick up an evaluation on your way out, and I guess give it to April, and she'll get it back to us. So this is just a very brief definition of what access to healthcare means. It's both the services of the healthcare providers and the facilities themselves. And when we're talking about physical disabilities, there's a lot of detail about physical access to the facilities, but we don't need to really talk about that in the mental health context so much. These are the laws that the rights come under, the ADA. Title II is public facilities, and Title III is public accommodations, which is fairly confusing. Public accommodations are private facilities that serve the public, but the law is similar under both. And then there's Section 504, which applies to facilities that get federal funds, which is virtually all facilities, and state laws, but it's not really important for you to know where your laws come from. I just kind of like to let people see the list. So you can divide the law about access to health care, and again, I'm talking about access to health care now strictly from like an anti-discrimination perspective. There's all kinds of other legal issues involving access to health care that we've like touched on here, managed care barriers and things like that, and HIPAA, but I'm gonna just talk about this particular from this particular perspective. So you're entitled to full and equal access to healthcare services and facilities. This applies to people with physical disabilities as well as people with mental health and cognitive disabilities equally. And that is essentially a non-discrimination mandate. And then there's the right to reasonable accommodations. Reasonable accommodations are defined this way as reasonable modifications to policies, practices, and procedures that are necessary to make the healthcare services available to people with disabilities. And then effective communication. And so we've already talked a lot about effective communication. It's largely discussed in terms of auxiliary aids and services. You know, anything that is required for a physical disability, like if someone has trouble hearing, you have to give them to there's information in print. If someone has trouble seeing, you could give them the information in spoken form, but it also, and sign language interpreters for people who use sign language, but it also applies to people with mental health disabilities and cognitive impairments. I hadn't really thought about this before, but I think telepsychiatry is sort of a good example of a form of effective communication for some people in some situations. You wouldn't want to force it on someone, but there may be people who have such barriers to coming into an office that that's their form of effective communication. Cultural competency is another, cultural and linguistic competency is another issue that's related to effective communication. I have some slides about that later. So here's more detail about discrimination. Here are some examples of what could be discriminatory conduct in a mental health, healthcare context when we're talking about people with mental health and cognitive disabilities. One is requiring someone to take a companion in with them to an appointment. If the person wants to go in alone, and that does happen, you know, we'll only see you if you bring the person who's sitting in the waiting room with you. That's not okay. Another is just the blatant refusal to provide services, which we've seen a couple of examples here. it is not okay to just walk away when you see the word schizophrenia on someone's chart. That's just a really, I'm going to use that example for now as my like blatant example of outright discrimination. And then harassing someone, making disrespectful comments is another form of discrimination. So then we get to reasonable accommodations. An accommodation is only reasonable if it's not an undue financial or administrative burden to the healthcare facility. So it's a balancing act, and accommodations are negotiable. So there has to be a connection between the accommodation you're asking for and your actual disability, what you need, and it has to not be an undue burden. So here are some examples of reasonable accommodations in the mental health context. Allowing a support person to come into an exam or a consultation if the person wants to bring the person that's in the waiting room with them. So you can't, it would be discrimination to require you to bring the person in with you, but it would be a failure to provide a reasonable accommodation if you didn't allow the person to come in. And then there's confidentiality issues, and you may, need to explain that to the person who's coming in. But another one would be allowing a psychiatric service animal. Unfortunately, this does not apply to emotional support animals anymore, but you do have a right to a psychiatric service animal, the distinction being that a service animal is individually trained to perform a service for the person with a disability that's related to the person's disability. Sometimes people with mental health disabilities need to have appointments at specific times, either because they have trouble waking up early in the morning because of the medication they're taking, or because they have other mental health, other types of appointments that conflict with the appointments that are available, whatever. There needs to be some flexibility in scheduling for that reason. And then taking extra time for a consultation, that I think is mostly applying to people with cognitive impairments who really need extra time to have things explained to them, and that has to be done. Of course, it would be unreasonable if you expected the doctor to take all day with you, but you do have to allow a reasonable amount of time, and you have to use formats that are accessible to the person. And then these are just other rights that I just wanted to bring up, that it's not just about discrimination. It's important to know what your rights are in the healthcare context, other than discrimination, and these are just some of them. Discharge planning is a pet peeve of mine right now, because I've had such negative experiences with clients being in hospitals, and the hospitals just not knowing what a discharge plan is. And it's such an opportunity to get care, both mental health care and physical health care, after you're discharged from someplace. But people don't know they have a right to a discharge plan, and very often it just doesn't happen. People who have conservators need to know that they have the right to challenge decisions of their conservators. And then there's the whole HIPAA confidentiality thing. You should know that you have a right to access to your medical records, and also to have your medical records confidential. HIPAA applies to all kinds of health information, not just psychiatric information. I'm not aware, I'd like to talk to you, Julian, about this issue of the consent, because I'm not a HIPAA expert. I mean, that would be really awful if you couldn't get, if that's what's happening. So I don't know about that. I do know the psychotherapy records are treated differently, but just the psychotherapist notes. Otherwise, my understanding of HIPAA is that mental health records and physical health records are both, HIPAA both protects the confidentiality and also gives you access to those records. But you don't want to make it, you don't want, of course, HIPAA to be a barrier to getting health care. It's supposed to help you. And then we've talked a little bit about culturally and linguistically appropriate services. The Civil Rights Act, and there's an executive order that says that recipients of federal funds, which is most, if not all, healthcare providers, must take reasonable steps to ensure that people with limited English proficiency have meaningful access to programs and services, including healthcare services. So you basically have a right to services in your language. It may not be a psychiatrist who speaks that language. If it's a language that they can't find a psychiatrist who speaks, it might be an interpreter, but you do have that right. And then, as Steve was saying, the HHS has not promulgated regulations about this yet, but they do have standards. There's a national standard for culturally and linguistically appropriate services in healthcare that says that that healthcare providers should provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So this is a really interesting topic all by itself. We did a seminar here once that focused on that issue too, but it's good to know that you have that right. And then this is how to address discrimination, the levels that you take it to, talk to your healthcare provider first if you have a concern. The healthcare provider may not realize that they're doing something that's discriminatory, and sometimes will change their practices if you bring it up. So you can talk to the individual provider, or you can also, many healthcare providers have ADA coordinators. You can talk to that person. And then you can file administrative complaints, and then I just give information for how to file administrative complaints. Now, full disclosure, this can be a very lengthy and difficult process to file administrative complaints, so I'm not saying this is an easy way to go, and that's why I would definitely go internally first to try to work it out. But, it does sometimes bear results, and agencies like mine can help walk you through the process if you need help with that. So there's just different agencies. We don't really have time to go through all this right now, but some of this information is in the fact sheet that's outside. Be aware that for the administrative complaints with the federal government, it's a very short deadline of 180 days from the time from the thing that you're complaining about. And then there's also the Department of Managed Care, which is, a lot of these issues have now become managed care problems, and so that's another route if your issue involves a managed care problem. And Medi-Cal fair hearings. Oh. And that's us. And that's Kelmy. So I'm sorry to rush through all that, but that's...
Well, we'll put you on first next time, Pam.
Sometimes talking fast has its advantages, I guess.
So this is the end of today's seminar, and thank you very much for your attendance and participation. People with Disabilities Foundation's next seminar will be on the topic of prisons and mental illness. And we ask the question, are prisons warehouses for people with mental illness or developmental disorders? If you would like to stay informed about that seminar, please be sure to sign up for our e-newsletter. So I'd ask to please give a very, very sincere round of applause to our speakers for generously giving their time and expertise today. Thank you, and thank you all for coming.